Cataract surgery presently in its state is more of a refractive surgery, and there are situations where the patients want to get rid of their glasses, especially the near corrections, and there are IOLs which can provide this facility. And so there are some issues which are to be handled when implanting such a lens. This is one patient who get rid of glasses and was planned for cataract surgery. And one peculiar thing which we can see here is that the pupil is not very well dilated in spite of mydriatic eye drops. This is the fundus, which is apparently normal with few tessellations. And these are two issues which we should understand when we are implanting multifocal IOLs. So we need to know the visual axis, the pupillary axis, and the optical axis. So usually these three axes are not actually the same, and the reason is that usually the eye's optical axis and the visual axis, they don't coincide. And there is one more element, that is pupillary axis, and we know these axes extend an angle among each other which is known as angle alpha and angle kappa. So we'll go ahead and see what does it mean. Basically, if you look at this diagram, which I have borrowed from cataractcoach.com, that is Dr. Uday Devgan, it shows us the reflex which forms on the cornea when the patient is looking at a illuminated pointed object. So these are the reflexes, and this is the left eye, and we can see there are three reflexes here, and each one of them denotes optical center, the pupil center, and the visual axis. So the optical center and the visual axis have to coincide as closely as possible, and then only we can have a patient who is fully satisfied. And center of the pupil is something which is again not usually aligned to this. So but in a situation where we are planning a multifocal or a IOL which will have number of focal points, it's important to have optical center and the visual axis coincide. And during surgery, how can we decide this? So keep the incision at the steep axis. This is important because it is not desirable that these patients should have any astigmatism. And clear corneal incisions, because they are very close to the center of the cornea, so they induce some surgeon-induced astigmatism, which can be used as a tool to modify pre-existing astigmatism. A rhexis which has to be sized properly so as to retain the IOL in the center. It should not be very large, it should not be very small, because small rhexis will overlap the peripheral optical part of the IOL, and a large rhexis will allow some amount of decentration. So it should be something like close to 5.5 to 6 mm so as to cover the peripheral edge of the IOL. I'm making a side port and proceeding for hydrodissection. Now at this moment we can appreciate that the pupil is not very well dilated, but I'll show that how this can be actually a useful conjunction to decide how well the IOL will perform. So we are going ahead with the phaco emulsification, and as usual using direct horizontal chop technique, and this is a Nagahara blunt chopper which has a blunt tip and an inner edge which is sharp, although it doesn't matter because basically we have to lacerate the nucleus. So going underneath the rhexis border and then crushing this tissue and then separating it, so making a figure of L. The primary chop has been done, and now rotating the nucleus for another chop, and I prefer that we should make multiple chops so as to make the pieces small as possible, so that the dissection of the nucleus and the emulsification process doesn't cause these pieces to protrude out into the anterior chamber or to touch the endothelium. Once the chopping has been completed, then we can proceed for picking up each piece and emulsifying it. As required, we can chop them as and when needed if the size is large. So the chopping of these pieces into smaller pieces can be done in one go, and they can be separately chopped one by one as they come to the handpiece. In small pupil, it's very important to safeguard the iris tissue, because iris, if it comes in contact with the phaco tip, it can get damaged, and this can be detrimental in these patients because pupil plays a very important role in optimum vision in these patients. We all know that pupil size has a role to play, especially to improve the depth of focus when it gets smaller as in attempted near vision. So the meiosis helps in aiding the focus for near. So once the emulsification has been done, we can see the pupil is small, something like 2.5 to 3 mm in size. Removing the cortex, and this becomes a little tricky because the cortical fibers which end at the rhexis border are being hidden here. So one has to be very vigilant, and at the same time has to remove all of the cortex, and one can always use a hook or a chopper to pull back the iris tissue so as to peek underneath and see if there is any retained cortex. Usually these are the steps where posterior capsular tear can occur, so that is why one has to be very dexterous and take care that the foot switch control is actively manipulating the vacuum and flow rate so as not to catch hold of posterior capsule. Once the cortex has been cleaned to satisfaction, we can proceed for IOL implantation. Any small debris which is left behind on the posterior capsule can be polished using the viscoelastic itself. So at this moment we can see the pupil is not very big, but it is providing us a port through which we can implant the IOL. And here I would like to mention that we can see the reflex of the microscope. These are the three lights which are visible. Two are the coaxial illumination lights and one is the oblique one. And right now we can see only the reflection from the cornea. Once we implant the IOL, we'll see the reflection formed by the IOL also. And now at this moment we have two reflexes which are formed. And these two reflexes, if they coincide well, and more so if they are centered, at the same time the patient is looking at the microscope. So we can see that these three reflexes, which basically reflect the optical center and the visual axis, if they are coinciding well and they are centered at the pupil, that means that the IOL is going to function well. At the same time, the concentric rings also have to be aligned. So all these four factors which I will just mention again: the center of the pupil, the reflexes which form the anterior surface of the IOL, and the concentric rings, if they are all well aligned, the patient will have full use of multifocality of the IOL. This is the post-op picture where we can see the post-op day 1 picture, which is a clear cornea, the pupil which is not very well dilated, but then it is good enough. This is the picture at day 7 where the effect of the mydriatic eye drop has been waned off, and this is the picture at day 30. And I would like to mention here that this patient gained 6/6 and near vision unaided N6, and this is what we are all striving for. Thank you.